I would like to remind everybody you can submit your questions via slido.com. Sport Swiss is the code. And our next speaker is right here beside me, is Carles again. With our next talk. We are simply happy to have you with us.
Thank you.
Placer.
Gracias.
Ciao.
Okay, good morning. Hope the party yesterday was good. Okay, so let's start because I have 15 minutes and a lot of things to say. So let's speak about the role of imaging in muscle injuries again. So first of all, if you ask a simple question and you ask, why do we have myotendinous junction injuries or myotendinous junction ruptures? And you can think about every single material in nature that you can imagine, okay? So it's all about overload that material, reach to an early fatigue, and then this material will fail. So there are a lot of aspects, there are a lot of components that produces that this material, in this case, the myotendinous junction or the muscle or the tendon, fails when it reaches an overload or a chronic overload state. They reach an early fatigue, and then when you demand something extra from that muscle, it fails and it has a rupture, okay? So this curve displaces to the left side, okay? That's quite easy in the theoretical aspect, but it's very difficult to apply. So this is one of the slides that I put also yesterday, and we have all these return to play criteria. I'm not going to stay here. I explained it yesterday, and we need to take care of that. So when we have an injury, we need to think about three important things regarding imaging. First one is the initial diagnosis, okay? This is the affected muscle, as I said, injury type, exact location, and affected structure. So you can see here in this drawing that the muscle and schema of, for example, what could be a biceps femoris, we can have a lot of different ruptures or tears or pathologies or issues in the same muscle affecting different types of structures. And we need to know which of them are we speaking about, because all of them have different types of treatment. So no diagnosis, no party. Second one, we can monitor the evolution and the quality of the scar tissue. And third one, we can assess the re-injury risk with some objective markers in the MRI scan. So let's just start with the initial diagnosis, and here we can see, first of all, we need to understand the anatomy, and this is very important. So we need to go back to the basics: anatomy, histology, biology, physiology. And this is one of these. So we can have tendinous, myotendinous, intramuscular, or myofascial, as I said. And here, this is a paper that we published recently this year. We can see a small table with the different types of tissue and their qualities in terms of prognosis and in terms of density or collagen structure. So I think it's quite important to understand that. So we also need, in the initial diagnosis, to look at the injury mechanism. It's not the same a high-energy mechanism that a slow-energy mechanism, for example, and consider all the risk individual factors that we can see in every individual, and obviously the clinical aspects. Because what we can see in the MRI scan, it's a tendinous injury. We can see myotendinous injury, which means a disattachment of the muscle fibers attached to that tendon or aponeurosis, but without any rupture of the aponeurosis itself, or we can see, which is very uncommon, a pure muscle injury. And all of these have a completely different treatment or management during the process of the return to play. So let's go with the quality and evolution of the scar tissue. So we can monitor the evolution and the quality of the scar tissue, and this is very important. This is also a slide that I put yesterday, but probably you will see that better in the next one, okay? So we have the initial stage. So this is an acute injury. This is the rectus femoris central tendon, okay? We have this acute injury. This is stage what we call 2A, which is around 2 weeks, between 10 days to weeks, okay? You can see that we start doing something in terms of hypertrophic reaction in the scar, okay? But in the center, it's still very weak and soft. But look at the stage 2B. The center part, which is still weak and soft, it's smaller, and the peripheral part, it's bigger, and it's more organized, okay? So we call that all the immature stage of the scar tissue, okay? And what we look here is to find the intermuscular and interstitial edema resolution, okay? But then we continue, and you can see that the scar tissue, it's continue progressing in terms of maturation until we reach the final stage, which is a complete mature and almost adapted to scar tissue, okay? And what we can see here is an adaptive edema if we apply a high loading demands to that area. So, for example, when I feel comfortable to say to a medical staff of a club, for me, I'm quite confident that this is going to be okay. It's when I pass the immature to mature stage. So from stage 3A, I feel quite comfortable to say, we can go. I'm a little bit more conservative, and normally I wait for the stage 3B. So if I see an immature scar at week 4 or no resolution, I'm not touching any button, and this is going alone. Okay, so we can see how old also is the injury, okay? So this is an acute injury. This is the soft scar stage in the beginning. Look that it starts organizing. Look at the T1. It's just starting organizing, but you can see that this is not of a good quality. Then you can see the hypertrophic scar stage, which you can see that it's quite mature but big in the middle. And then finally, after a month, you don't have to wait for that for continue with your sport normal. We have a complete and thin and completely adapted scar tissue, okay? But where do we need to take care here? Here is the key risk point during the process. And this is around 0 to 3 weeks, depending on the injury, of course, okay? So when we assess the re-injury risk, we can recognize different edema patterns. And this is what I said yesterday. And you can see different types of edema here. We can see a cotton pattern edema. It's like you use a cotton next to the scar tissue. We can see some perilesional annular edema around the scar tissue. We can see some kind of fluid in between muscles or next to the scar tissue. And finally, we can see what is a feather pattern edema, a clear feather pattern edema, okay? So depending on the edema, and this edema will appear after some kind of loading, we can say that a cotton-like pattern edema means adaptation to the load we are applied. Perilesional edema pattern is still reparation ongoing. An intermuscular bleeding suggests tissue or adherence ruptures, and the feather pattern edema means suffering or overload of the structure. So we can monitor that during the process. Of course, it's just an information, as I said yesterday, okay? But I think it's very useful to have that because, for example, this feather pattern edema was in a completely asymptomatic player in the last stages of his rehab after a big injury. And it can be seen that all the hamstring muscle group is suffering, okay? So if I see feathery or intermuscular edema, I suggest to reduce a little bit load and go a little bit more progressive than normal. So the matter is, if you understand what you're seeing, you can be calm because you understand what's going on. Okay? The problem is that if you don't understand and you see a lot of edema or some type of edema, you start getting nervous, and everyone in the club or everyone in the team starts getting nervous because what's going on here, this is not progressing good. So we need to understand what is going on, and also we need to understand that sometimes in severe injuries, as an adaptive process, we can end with a split in a tendon, for example. And that doesn't mean that there is a rupture there. So we published that in 2023, and these are 5 objective markers that you can have in an MRI before the return to play to see if there is a high re-injury risk or not. Okay, so 1 week before the return to play, we perform an MRI scan. Nothing changed, but if we find 2 or more of these objective markers, there is a high risk for a re-injury during the next month. Okay, these are quite obvious. There's a callus gap, it's normal, connective tissue gap, loss of tension, feather pattern edema, or intermuscular edema, as we spoke. Okay, so our main goal when we have an injury is to put the player again into the return to play, and we need different stages. So repair, rehab, recovery, reconditioning the player, performance, and finally the complete return to play. But when we plan this process, and I forget the imaging in this stage, we make some kind of steps. So stage 1, stage 2, probably stage 3, and stage 4. And we design a return to play time, that it's decrease inflammatory signs, pain-free, range of motion initially, healing process, then restore normal mechanics, and then from stage 3, increase load, analytical working, and then progressing from here until the medical clearance, and then the complete transition to individual and to the cows into the field, okay? And then the sports clearance finally, okay? So this process should be a combination and a very high communication between all the professionals involved. That means medical doctors, physiotherapists, and physical trainers. Probably medical doctors more in the beginning, less in the final stages, but they all need to speak, and it's a matter that something doesn't happen, okay? So, just to end, this is the same slide as I put yesterday, but let's take this slide according to the one we just have passed. Okay, so we have the biology, histology, we have the imaging, and we have the clinical aspect, okay? We plan the return to play, and if everything is perfect, that works, okay? But we have a lot of issues when we plan that return to play that you can see here, and especially in a sports team, or even in a non-professional athlete. So what can happen due to a lot of factors, external factors, is that this biology and this imaging delays regarding the clinical aspect. So this is chronifying or making longer and bigger the soft scar stage. That means that when you are here, in this point where we start cows and when we start field training, we will have still a non-mature scar tissue. And that means that if we applied high loading demands with a non-mature scar, the re-injury risk is quite high. So that's the importance of the imaging during all this process, okay? And this is all the literature reviewed, but for me, a very important one is that last one because it speaks about the communication between all the professionals involved in the return to play process. So as a final summary, what I should take home from these images is that the best prognosis factor is have a very, very accurate diagnosis from the beginning. So we need to know exactly which structure, which muscle group, which structure, which type of injury we have. Is it myotendinous? If it's tendinous. Based on the diagnosis, and this precise diagnosis, we need to be tailors of return to play processes. It's not just a protocol. I get a protocol from that journal. No, no. We need to be absolute tailors of every single individual injury. Imaging test, for me, and I know Rod is not thinking the same, but for me have a key role during the whole process, not only in the beginning. Communication, it's absolutely crucial for a safe return to play. Everybody involved in a professional sport needs to leave the egos outside the door and work together for the sake of the athlete or the amateur player. Quality of the scar tissue. We can see with ultrasound the scar tissue, but we cannot see with ultrasound properly the quality of this scar tissue. And this is very important if you want that kind of information. And the most important problems for me are re-injuries. We need to consider that re-injuries has a very poorer quality of the tissue in that area. So the clinics is less, the mechanism is quite confusing, so everybody thinks that's not important. No, it is. It is more important even than the initial injury. So we need more time to return to play a re-injury rather than initial injury because of the quality of the scar tissue that remains there. And finally, it is essential to have an initial diagnosis, as I said, as accurate, secure, and concrete as possible. And as always, be careful with the classification system because we need to use there just as a starting point and depth deep inside every single injury. Thank you very much.